Hi everyone, Dr. DeFelice here, and today we are going to be talking about
therapy questions with dichotomous outcomes. So you will remember last time we talked about therapy questions with continuous outcomes. And the continuous outcomes were the outcomes that could keep continuing on a number scale, like blood pressure in millimeters of mercury, age, stuff like that. This time we're doing dichotomous outcomes. Dichotomous outcomes are yes or no, alive or dead, pregnant or not pregnant, just a choice of one thing or the other. So by the end of part 2 of module 1 on therapy questions, you will be familiar with applying the PICO format to the therapy question, like you were last time. You'll be able to analyze therapy articles with dichotomous outcomes for validity, precision, and applicability to our patient. We're going to talk again about intention to treat analysis. And there are other things, other measurements that we can use for measuring dichotomous outcomes. And those are risk ratios, which would be relative risk reduction, and absolute risk reduction. We'll also talk about number needed to treat again and number needed to harm. So recall that in a therapy question, to answer it, we're usually looking for a randomized controlled trial, which again, we have our sample population, we have randomly assigned to separate groups. There's the group that receives the intervention, and there's the group that is the control group or receives the standard of care, like we saw in our last journal article about the PAD. And then we are looking at the outcomes, this time dichotomous outcomes. So here is our clinical scenario. A 79-year-old woman with advanced heart failure comes to the office. She heard about how a medication called spironolactone prevents mortality or death in advanced heart failure patients. She wants to know if she should take spironolactone. She schedules another appointment for next week, and the attending physician asks you to do some research on this and report back. So the first thing we have to do is to form our PICO question. And remember, the PICO stands for patient, intervention or exposure, comparison intervention or exposure, outcome, and T is the type of clinical question being considered. So in this case, we are thinking about patients with advanced heart failure, or our specific patient was, I believe, 79 years old, a 79-year-old woman with advanced heart failure. The intervention is spironolactone. The comparison could be placebo. It could also be the standard of care. The O is our outcome. So we want improved survival. And the type of article that we're looking for, the type of question that we have, is a therapy question, which is usually answered by a randomized controlled trial. So we are looking for a therapy article that answers the question, among patients with advanced heart failure, does spironolactone versus placebo improve survival? Or versus standard of care? So we put in, remember, we pick a couple of search terms. So I would pick spironolactone and heart failure as probably our two search terms. And if you're searching, for me, I would probably go to PubMed first, but you do have access through the school to some subscription journals. So I found this article. Now, this article is an old and classic article from 1999 from the New England Journal of Medicine. It's a famous article, The Effect of Spironolactone on Morbidity and Mortality in Patients with Severe Heart Failure. So first, let's read the abstract to see if we can apply this to our patient care. So let's look at the abstract. Background and methods. Aldosterone is important in the pathophysiology of heart failure. In a double-blind study, We enrolled 1,663 patients who had severe heart failure and a left ventricular ejection fraction of no more than 35%, and who were being treated with an angiotensin-converting enzyme inhibitor, a loop diuretic, and in most cases, digoxin. So it looks like they enrolled patients with advanced heart failure, and they were all on the standard of care. A total of 822 patients were randomly assigned to receive 25 milligrams of spironolactone daily and 841 to receive placebo. The primary endpoint was death from all causes. Results: the trial was discontinued early after a mean follow-up period of 24 months because an interim analysis determined that spironolactone was efficacious. So that's important to keep in mind. And then the conclusions of this article are the blockade of aldosterone receptors by spironolactone in addition to standard therapy. So we have in addition to standard therapy, substantially reduces the risk of both morbidity and death among patients with severe heart failure. So this sounds promising. Let's go ahead and assess our article. So, like we did with our continuous outcomes article, we have three things that we want to assess. We want to assess validity or risk of bias. We want to assess the results for effect size and precision. And we want to assess for whether or not this particular medication is applicable to our patient. So first, we assess validity. So when we're assessing validity, we have some questions that we're going to ask. We are going to ask, were patients randomly assigned to treatment groups? Was allocation concealed? Were baseline characteristics similar at the start of the trial? Were patients blinded to treatment assignment? Were caregivers blinded to treatment assignment? Were outcome assessors blinded to treatment assignment? Were all patients analyzed in the groups to which they were originally randomized? And was follow-up rate adequate? So we'll start with the first two questions. Were patients randomly assigned to treatment groups, and was allocation concealed? So I hope you have your journal article handy so you can look to find these areas in your journal article. We see that in the procedures section, that after the initial evaluation, patients were randomly assigned in a double-blind fashion to receive either 25 milligrams of spironolactone once daily or a matching placebo. So the answer to both of those questions is yes. The next question we're going to ask in assessing validity is, were baseline characteristics similar at the start of the trial? So we are looking at the baseline characteristics of the patients or the participants in the study. And usually we see table 1 usually lists the baseline characteristics so that we can just kind of take a glance and really look at it. But we saw in our results section, if you find that in your article, as highlighted, it says, as shown in table 1, the two groups had similar characteristics at baseline. So let's look at our characteristics. We have age in years. So the placebo group, N equals 841. That's our sample size, 65 years of age, plus or minus 12. The same in the spironolactone group. Sex, male and female, pretty well distributed. Blood pressure, pretty even baseline characteristics. And we can go down further and further down the list to see whether the baseline characteristics were comparable between the two groups. Next, we can ask these three questions together. We can ask, were patients blinded to treatment assignment? Were caregivers blinded to treatment assignment? Were outcome assessors blinded to treatment assignment? So we look back in the procedures section of our article, and we can see after the initial evaluations, right, we said that they were randomly assigned in a double-blind fashion. So they were assigned in a double-blind fashion, and So the patients didn't know if they were receiving the spironolactone on top of their current treatment or the placebo on top of their current treatment. So patients, yes, were blinded to treatment assignment. Were caregivers? Well, it says it's in a double-blind fashion. So a double-blind fashion means that patients are blinded and caregivers are blinded to whether or not they are receiving or distributing the placebo or the actual medication that we're studying. And we want to know, were outcome assessors blinded to treatment assignment? And at the bottom there in the yellow, we see an independent data and safety monitoring board periodically reviewed the results in a blinded fashion. Event committees whose members were unaware of the patient's treatment assignments assessed the causes of death and reasons for hospitalization. So here's a question to think about. Why do we need to have everyone blinded to the treatment and the treatment assignments? Just a question for you to ponder and consider. Next, we ask, were all patients analyzed in the groups to which they were originally randomized? So we see in the statistical analysis section that the analysis of death from all causes, which was the primary endpoint, included all patients according to the intention to treat principle. So it looks like, yes, all patients were analyzed in the groups to which they were originally randomized. So remember, we all talked about intention to treat analysis, and we talked about the difference between intention to treat and per protocol analysis. So intention to treat means that we include all the participants who were originally randomized to the study in the overall analysis, whether or not they don't complete the full course of treatment. If we only include the people who do complete the full course of treatment, that's called a per protocol analysis. So we would do that if we're just trying to find out the biophysiological effects of a medication or something, but to really see how the therapy would work in real life, because there are things such as side effects and people forgetting, and you want to see how effective, how efficacious your treatment is going to be when it is used in real life. So the intention to treat analysis gives us a better idea of real life scenarios than the per protocol analysis does. So was follow-up rate adequate? So this is the interesting part from the abstract, which we read before. The trial was discontinued early after a mean follow-up period of 24 months because an interim analysis determined that spironolactone was efficacious. So yeah, they stopped the study early because they were like, ooh, this stuff's good. Let's get it out there. So when we're looking at validity and risk of bias, I would say we have a high level of validity and a low risk of bias because we answered yes to all of those questions that were asked. So next, it's time to assess the results for effect size and precision. And for assessing the results, we have two questions that we want to ask. We want to ask, how large was the treatment effect, and how precise was the estimate of the treatment effect? First, we start with how large was our treatment effect. We have to figure out, is our primary outcome continuous or dichotomous? Well, because of the title of this whole lecture, we already know that the primary outcome is dichotomous. The primary endpoint was death from any cause. Is the person alive at this time span, or is the person dead? So that's our dichotomous outcome. Remember, in our continuous outcome, we looked at the mean difference between groups. So that would be the difference between the mean in the control group and the mean in the treatment group. And we wanted to see how large those differences were. In dichotomous outcomes, we have some other ways of measuring how large the treatment effect was. So, like I said, on the bottom there, you see continuous outcomes like blood pressure in millimeters of mercury, quality of life on a scale of 0 to 1. The summary of results within each group column says we're looking at the mean, right? The mean blood pressure, and then the comparison of results between the two groups is the mean difference. We just talked about that. When we, however, talk about dichotomous outcomes, which is lived or died, blood pressure controlled or not controlled, we can look at our summary results within each group. So we can either look at proportion, which can be expressed as deaths per 100 patients, or we can look at rate, which is deaths per 100 patients per year, for example. We're going to concentrate right now more on proportion, and we're going to look at the comparison of results between two groups for dichotomous outcomes, and we will see that we have some risk ratios. We have relative risk reduction, absolute risk reduction, and relative risk. So this is what we're going to be talking about. So once again, we have our 2x2 contingency tables. And when we talk about these tables, it's just a way of organizing our information so that we can just plug and chug into these formulas. So on our relative risk contingency table, we have the outcome. Let me see if I can do this. All right, we have our outcome, right? And our outcome is, in this case, we're going to look for deaths, right? So we would see here, did the outcome happen? Yes or no? And did that patient receive the treatment under the study? Yes or no? So if we had a certain number of patients here that died and also received the treatment, we would put that number right in here. For the people who received the treatment and stayed alive, we would put that number right here for B. For people who did not receive the treatment and had the outcome of death, we would put that number here. And for people who did not receive the treatment and did not have the outcome of death, we would put that number here. And then we plug and chug into our formulas here. So we have our relative risk formula up here, which is A divided by A plus B, all divided by C over C plus D. Okay, so that would be, so this is our relative risk right here, R. The treatment group risk, so the risk of this outcome in your treatment group, right? Because this number over here is A plus B over the control group risk. So these people are in the control group, and you want the risk of the outcome in this control group. And this number over here would be C plus D, okay? We will look at an example of that in a minute. But first I want to talk about how you interpret relative risk. So there are three levels of interpretation. Relative risk is less than 1. That means treatment is beneficial. If relative risk is equal to 1, that means there's no effective treatment. And if relative risk is greater than 1, it means the treatment is harmful. So you're looking at a ratio, right? And let's look at the relative risk being equal to 1. If your numerator and your denominator are equal, then you get 1, and there really is no effective treatment there because there's no difference between the top number and the bottom number. There's no difference between the treatment group risk and the control group risk. So if your relative risk is 1, there's no treatment effect. And then you just have to remember, if it's less than 1, we find the treatment to be beneficial, and if it's more than 1, we find the treatment to be harmful. Next, we look at something called relative risk reduction. And relative risk reduction is just 1 minus the relative risk. When we interpret relative risk reduction, we are looking at greater than 0. That would be treatment effect is beneficial. Equal to 0, no effective treatment. Less than 0, treatment is harmful. So absolute risk reduction is something different. Absolute risk reduction, first of all, we have our 2x2 contingency table again, and we fill it in the same way. And our formula this time is C over C plus D minus A over A plus B. And we talked about absolute risk reduction a little bit last time when we talked about number needed to treat. But let's talk about it again. When we talk about C over C plus D, we're talking about the control group risk. And when we're talking about A over A plus B, we're talking about the treatment group risk, right? So this is, so the treatment group risk would be A over whatever the total number is of people who did receive the treatment over here, A plus B. And then when we're talking about the control group risk, these people did not receive the treatment. So we're talking about C over the entire number of people that did not receive treatment. So that would be C plus D. So basically we can say the absolute risk reduction is the rate in the control group minus the rate in the treated group. And once again, this is interpreted pretty similarly to relative risk reduction, where treatment is beneficial if it's above 0%, no effective treatment if it's equal to 0, and treatment would be harmful if it's less than 0%, okay? So let's kind of look at this. This is from a cool book. It's called Painless Evidence-Based Medicine. You can see the citation there in the corner. It's kind of an analogy here. So they're saying, imagine that you went on a diet and lost weight from 80 pounds to, or 80 kilograms to 60 kilograms. So if we look over in this column over here, you can't see my thing. Okay, if we look over here, this is our weight analogy. So we're asking, in what ways could we express our change in weight, excuse me, if it went down from 80 kilograms, so that would be weight at the start, to 60 kilograms, so that would be weight after, right? After you've received therapy or whatever. So in what ways can we express the change? We can say, well, I lost 20 kilograms, and we can call this the absolute weight reduction, which we can compare to the absolute risk reduction. Okay, it's just the difference between the two risks. Absolute risk reduction is just the difference between the rate in the control group and the rate in the treated group. It's absolute. And we can see the interpretation over here. Another way that we can express our change in weight is, I lost 25% of my weight. And we can call this relative weight reduction. And we see that we can express it in this type of formula. We can also compare it to, I lost 25% of my risk. And so that would be relative risk reduction. And that interpretation is given over here. Finally, we can say relative weight. I now weigh 75% of what I used to weigh. That's our relative weight. You can compare this to relative risk. My risk is now 0.75 of what it was. Here's our formula, and here's how we interpret it. Okay? So how large was the treatment effect in our article? First of all, we have this great curve. It's called a Kaplan-Meier curve. And this is an analysis of the probability of survival among patients in the placebo group and patients in the spironolactone group. So we can see our patients in the spironolactone group over here, our patients in the placebo group, and this is the probability of survival as we go up on the y-axis, and the time is as we go out on the x-axis. So over time, we see that our probability of survival with for those on placebo was not quite as long. Not so many people survived at these different time periods, right? So we see way more people were surviving with the spironolactone in addition to the standard therapy rather than placebo in addition. So they said the risk of death was 30% lower among patients in the spironolactone group than among patients in the placebo group, with a p-value of less than 0.001. So, and we are looking for a p-value for statistical significance of less than 0.05. And let's look at table 2 here. We have table 2 is our relative risk of death and hospitalization. So when we're interpreting relative risk, we have to keep in mind that relative risk less than 1 means our treatment is beneficial. Relative risk equal to 1 means that there's no effective treatment. And a relative risk greater than 1 means that the treatment is harmful. So let's just look at our primary outcome is death. So cause of death, cardiac causes. So we see a comparison between the groups, and then we see that our relative risk here is 0.69. Is that less than 1, equal to 1, or greater than 1? Well, it's less than 1. And it's got a pretty low p-value, so that indicates that treatment is pretty beneficial. We see here our 95% confidence interval in the parentheses. So you want your 95%, you want both tails of your 95% confidence interval to be less than 1 to say that this treatment is beneficial. If your confidence interval crosses the line of 1, so if your 95% confidence interval was like, I don't know, 0.58 to 1.3 or something like that, then you can't say with any statistical significance that your treatment was beneficial. So all of these we see spironolactone was beneficial for all of these outcomes. This is another way of expressing relative risk. This is called a forest plot. And I prefer these because it's a very visual and it's very much, you can tell in a glance whether the relative risk is less than 1 or more than 1. So remember we said if relative risk is less than 1, that means the treatment is beneficial. If the relative risk is greater than 1, that means the treatment is harmful or the placebo is better. So this is relative risks of death from all causes. These lines here are, so this is the mean, and the ends of the lines, the little whiskers here, represent your 95% confidence interval. So like I said before, you don't want this line to cross the 1 because that reduces your statistical significance. So what do we have here? I'm not sure what we're measuring. Use of digitalis, no. This crosses the line. So we can't say with certainty whether spironolactone would be better without digitalis, it looks like, or with digitalis. It says with digitalis, it looks better. But without digitalis, it looks to have kind of like a summative effect with digitalis. It seems to also have a summative effect with an ACE inhibitor. So if you're not on an ACE inhibitor, then spironolactone doesn't look to be as beneficial because it crosses that relative risk line than it does if you are on an ACE inhibitor. So we will see forest plots again. They're especially common in systematic reviews. So we'll talk about those again next week. But moving on. So once again, we have relative risks from the combined endpoints of death or hospitalization in the spironolactone group. We just look at our numbers relative risk, less than 1, treatment beneficial. And this is what we see for all of them. So how large was our treatment effect? It was pretty statistically significant. How precise was the estimate of the treatment effect? Well, what do you think? I want you to look back at that forest plot. Look at the 95% confidence intervals. What's your judgment at this point? Do you think the estimate of treatment effect was real, or was it just a result of chance? Next, we assess for applicability to our patient. So we ask the questions, were the study patients similar to my patient? Were all patient important outcomes considered? And are the likely treatment benefits worth the potential harm and costs? We can answer our first two questions together by looking back at our patient. She was our 79-year-old woman with advanced heart failure. She heard about how a medication called spironolactone prevents mortality in advanced heart failure patients, and she wants to know, should she take spironolactone? So I think that if we look back on, we're moving forward. If we look back to our baseline characteristics in table 1, you can see that she pretty much fits in with our participants. And she also wants to know about the primary outcome of death. So that is exactly what our study covered. And her patient important outcome in this case was preventing death. Now, sometimes, as we mentioned before, people have problems with cost. People have problems with side effects. People have problems with accessibility. So those are all patient important outcomes to be considered. In this case, our patient only had that one important outcome. And yes, that outcome was considered in our article. Then we have to ask, are the likely treatment benefits worth the potential harm and costs? And we'll look at the number needed to treat, number needed to harm. So let's calculate number needed to treat for potential benefit. So remember, the number needed to treat is the number of patients the clinician must treat over a particular period of time to prevent one adverse target event or create a positive outcome. The number needed to treat is the inverse of the absolute risk reduction. And remember, we talked about absolute risk reduction before. So absolute risk reduction is just the rate in the treated group, the rate in the untreated group, subtracting the rate in the treated group. Okay? So absolute risk reduction is C over C plus D minus A over A plus B. We take that number, we put it under 1, and we get our number needed to treat. And remember, number needed to harm is negative 1 over the absolute risk reduction. So in our study, we are going to look at the total deaths in the different groups. And we are going to see what is the number needed to treat. So remember, number needed to treat is 1 over the absolute risk reduction, the rate in the untreated group minus the rate in the treated group. So let's look at our numbers here from table 2. Let's fill this out. Our outcome we're looking at is death. So how many people received the treatment and also had the outcome of death? We see that number down here, 284. So we fill in that number right there. We see that our N, our sample size, is 822. So that is our A plus B, 822. And then we just subtract the 284 from the 822 to get the 538. These are the people that had the treatment and did not have the outcome of death. Then we move on to people who did not receive the spironolactone. The number of these patients who died was 386. Our sample size was 841, so that's our C plus D. And then we can just subtract the 386 from the 841 to fill in this column of people who did not have the treatment and people who did not have the outcome that we're measuring. So if we plug and chug, we take our numbers from here and we plug it into our formula for absolute risk reduction and then for number needed to treat, we get this. Number needed to treat would be 1 over 386. This is your 386 divided by 841 minus 284 divided by 822. We do the math. Boom, boom. 9 patients would need to be treated to prevent 1 death. Okay? So 9 patients would have to be treated with spironolactone in addition to the standard treatment that they're being given to prevent 1 death. So this is interesting because you can then compare the number needed to treat with other heart failure treatments. And this is from a study that appeared in the American Family Physician. It's kind of cut off on the bottom there, back in 2001. And we see number needed to treat for different drugs in congestive heart failure. Okay, so we have our ACE inhibitors and our number needed to treat. And these are different classifications of heart failure, how severe the heart failure is. It's the New York Heart Association, class 1, class 2, class 3, and class 4. You can measure how severe. And so class 4 would be the most advanced heart failure patients. So we see spironolactone right here. The number needed to treat is 9, which we figured out right there. And the outcome prevented is 1 death over 2 years in patients with advanced heart failure, New York Heart Association class 4 heart failure. And, this is just a comparison. Not all of the studies compare the exact same thing. Like this study that studied digoxin, their outcome that they were looking at was emergency department visits or hospitalizations. Hydralazine and isosorbide dinitrate, they were looking at death over 1 year. Here they were looking at death over 2 years. So these are just things to keep in mind. I'm sure we could statistically compare these things, but we're not going to. We're just going to look at number needed to treat. And for number needed to treat, spironolactone looks really good for people with advanced heart failure. Now, ACE inhibitors look really good, but in addition to ACE inhibitors, we can add spironolactone on. So what do you tell the attending physician regarding what your research told you? That's what I would like to know. So in your, that's what I would like to know. And this is your article reference for this article. And the other things that I have referenced are referenced throughout the presentation, and you can go back and see them. So I will see you next time. And if you have any questions, feel free to reach out to me.